professor in the Department of Health Systems and Population Health at the UW School of Public Health. And today I'm going to be talking to you about some of the work that I've done as part of my K-12 Career Development Award. And in particular, I worked on culturally adapting an intervention that helps caregivers to better manage behavioral and psychological symptoms of dementia. And the cultural adaptation was done specifically for Latino populations. So as you are probably all aware, family members are the largest sources of care for people living with dementia. And they face overwhelming challenges and often without adequate education, skills training, and support. And caregiving is further complicated by the behavioral and psychological symptoms of dementia that most people living with dementia will come to experience at one point or another throughout the course of their disease. Latinos are 1.5 times more likely to develop dementia compared to non-Latino white adults. And while all caregivers are at higher risk of adverse outcomes in terms of their mental and physical health, Latino caregivers in particular are at higher risk because they provide more hours of care and have less professional support for doing so, especially when it comes to managing symptoms. STAR Caregivers, or STAR-C, is an efficacious intervention that teaches family caregivers how to better manage behavioral and psychological symptoms. It was developed by Linda Terry and Sue McCurry, and the intervention involves in-home visits by a health professional who's trained as a consultant. And this consultant visits caregivers in their homes on a weekly basis over a period of 6 weeks. And then they have some follow-up monthly phone calls after that initial 6-week period to check in and make sure that the caregiver is maintaining gains. So there are 6 core, or I should say 5 core components here listed across the top that make up the STAR-C intervention. The first one being helping caregivers to better understand dementia and having realistic expectations about how dementia will impact mood and behavior. The next is teaching caregivers effective communication strategies that they could use to reduce behavioral symptoms of dementia. And then the next one, which is, I think, the main aspect of this intervention, is helping caregivers to learn the ABC problem-solving strategy. A stands for activators, B for behavior, and C for consequences. So caregivers learn to identify a target behavior, and then they're taught how to observe the behavior to identify the activators, what comes immediately before the behavior, and then the consequences, what happens immediately after the behavior. And then they brainstorm ways in which they could change either the activators or the consequences as a way of reducing the target behavior. Caregivers then go on to learn about the connection between pleasant activities and mood, and they learn to formulate pleasant activity schedules, not only for the person living with dementia, but also for themselves. And then the intervention ends with teaching caregivers strategies for better coping with caregiving. So they learn about the importance of leveraging their networks to help lift some of that caregiving load, whether it's reaching out to family members or friends, or hiring professional help. Recently, STAR-C was adapted to be an entirely virtual intervention. And the purpose of that was to ease implementation in clinical settings. The virtual intervention is referred to as STAR-C, Virtual Training and Follow-Up, or STAR-VTF. And the development and testing of this intervention is being led by Rob Penfold at Kaiser Permanente, Washington. In this STAR-VTF version of the intervention, caregivers complete 6 online training modules asynchronously. So rather than getting the training by the consultant in person, they do the training online on their own. It's like a self-directed modules. And the modules are made up of a combination. They're essentially slides with text, images, and voiceover. In addition to those modules, the caregivers have 6 30-minute weekly phone check-ins with the consultant. And then after those initial 6 to 8 weeks, they can reach out to the consultant for ongoing support as needed through the KP patient portal. Neither STAR-C nor the virtual adaptation were explicitly developed with consideration of Latino families. And so I was really interested in understanding whether we needed to adapt the intervention, and if so, how we might need to adapt the intervention to improve its cultural and linguistic appropriateness for Latino populations. To guide this work, we use the Cultural Treatment Adaptation Framework, which I've included a screenshot here on the slide. This framework is data-driven, and it provides basically a common language that we could use when we're adapting evidence-based health interventions for particular racial and ethnic groups. So as you can see across the top, the highest level of adaptations are either to the peripheral components or to the core treatment components. So in terms of peripheral components, we can make adaptations to engagement, so how we're engaging participants, or treatment delivery in terms of the materials and semantics we use, or adding cultural examples and themes, etc. Or we may find out that we need to make adaptations to the core components of the intervention, whether that's a complete change, adding a core, or simply modifying what's already there. So we use this framework both to guide the interview questions that we would ask participants, as well as our data analysis. So we conducted 44 qualitative interviews. We recruited 30 Latino caregivers from Kaiser Permanente, Washington, from UW Medicine, and also from the community. In terms of the community, we posted flyers in tiendas or Latino oriented grocery stores, both here in Western Washington and in Eastern Washington. And we also made radio appearances and had advertisements in Spanish radio stations in Eastern and Western Washington. The eligibility criteria for caregivers was that they identify as Hispanic or Latino, Latina, Latinx, age 21 years or older. They were the child, spouse, partner, or close friend of the family member of the person living with dementia, and they lived with them or at least within 5 miles, and provided at least 8 hours of care per week. We also recruited 14 healthcare and social service providers that had expertise working with Latino clients, whether they were older adults, people living with dementia, or their family caregivers. And prior to the pandemic, we conducted interviews in person, and then during the pandemic, switched over to phone calls or Zoom, and used qualitative research methods to code and analyze the data. Here I list the characteristics of our study participants. In terms of caregivers, 67% identified as Mexican, Mexican American, or Chicano, Chicana. 67% identified as women. 60% preferred to speak Spanish. 63% were the adult child of the person living with dementia. And 70% provided 35 hours or more of care per week. In terms of providers, 64% were health educators or case managers, and 71% identified as being Spanish, English, bilingual, and bicultural. I'll present 3 of the major findings from these interviews, beginning with the need that we identified of increasing awareness about dementia and decreasing stigma. So we found out that a common belief in the community is that dementia is inevitable in older age. We also found out that that caregivers were not informed, for the most part, at diagnosis, that people living with dementia would eventually likely come to experience significant changes in their mood and behavior. And so they were quite surprised when this began happening and felt very unprepared for how to handle that. We also asked caregivers directly if they had spoken to their healthcare providers about some of these changes in mood and behavior. And we found out that most people hadn't, because for different reasons, but there was a reluctance to speak to providers about this because in the community, it's commonly believed that dementia and Alzheimer's disease is a mental health condition, and people are called crazy if they have that condition. And so there was a little bit of stigma and reluctance and a little bit of embarrassment to talk to providers about some of the strange things that they were observing in their family member at home. A good portion of people also told us that they were just unaware that providers could help with symptom management, and even saying things like, I didn't think it was relevant to the conversation with the provider. So in response to this finding, we expanded the content in the first module in the section titled Overview of Dementia. And I included a screenshot here of the first slide in that section. We spend about, the original STAR VTF module spends about 7 minutes or so giving an overview of dementia. And we thought that for the Latino population, it'd be better if we expanded this section and emphasized these topics and just spent more time providing education about dementia. And also to explicitly state that Alzheimer's disease and related dementias are not a normal part of the aging process. We give examples of normal aging versus signs of dementia. We explicitly state that Alzheimer's disease is a brain disease, and that behavioral and psychological symptoms are common and unintentional and are part of the disease. And then we also acknowledge that some people may feel reluctant to speak to physicians about some of the changes that they're observing in their family member, but that help is available for them. The second major finding was the need to eliminate stigmatizing, offensive, and culturally inappropriate language. Because of the stigma associated with the disease in the community, there was also stigma associated with using the terms or the words Alzheimer's and dementia to describe their family member's condition. People, and even when there's a diagnosis, people prefer to use the term memory loss to describe the condition. We also found that there's a strong dislike for the intervention content using negative adjectives to describe the symptoms. So currently the intervention content uses words like bothersome, problematic, challenging to describe the symptoms. And people found that off-putting. Like some people interpreted those words to be describing the person with dementia rather than their symptoms. And they just preferred not to use that type of negative language. There was also a strong opposition to using the word burden to describe the caregiving experience. And I want to just emphasize that or make clear, because sometimes when I share this finding with people, they think that Latino caregivers don't experience burden. But I want to make clear that it's not that they don't experience burden, because they do. It was clear through the stories they told and what they shared with us that caregiving has negatively impacted their physical and mental health. But they just don't like using the word burden to characterize how caregiving has impacted them. Generally speaking, providing care to an older adult, an aging parent, a sick family member is highly valued. It's a highly valued part of the culture. It's if they feel like it's a responsibility for them as being a member of a family, and to describe it as a burden feels a bit offensive. And then finally, we found that most people that we spoke with don't actually identify as a caregiver, or they don't use that word to describe the work that they do. And the word in Spanish, cuidador, is not commonly used. So when we ask caregivers, well, what do you prefer to be called? They simply wanted to use kinship terms like I'm the wife of the patient or the daughter, or whatever the relationship is. And there was also a lot of confusion about what caregiver actually meant, like who is considered a caregiver, with people thinking that caregivers are people who do it as a profession, who get paid for providing care. So here's an example of how we modified the language in the content to get rid of some of these, or to prevent some of these problems that we found through our interviews. In this particular example, it's eliminating the use of the word burden. So in this slide, it's asking caregivers to identify or to think about who in their life could help with caregiving and what they could do to give them a hand. And as you'll see in the bullet point here, it says that sharing the burden can boost your health and make it easier to problem solve. So in the adapted version, we rephrase that bullet point to not use that word. And instead, we say having other people help take care of your family member is good for your own health. So it's simple changes, but I think these changes will make a big difference in how people perceive the content. And then the final major finding is the need to incorporate the Latino family structure and the nature of caregiving in Latino families. And so I mentioned earlier that last module of the intervention, it talks about coping with caregiving and suggests hiring help or professional services as an option for coping with caregiving. But we actually found that the vast majority of people didn't use formal support or paid support because it was prohibitively expensive for them. And instead, they relied extensively on support from family members and friends. All but 2 or 3 of the caregivers that we interviewed lived in close proximity to family members and friends that provided help in one way or another with caregiving. A third of the people that we interviewed lived in multi-generational homes, including with children under the age of 18. And they talked about how even the children helped to provide care in some way or another. Like one of the caregivers said that her 4-year-old grandson takes care of his grandpa with dementia while she goes and takes a quick shower. So they gave us lots of examples of how family and friends, how they rely on family and friends to give them short breaks. And then from providers, we heard that there's a lack of programs that consider the family unit, and that they thought this was particularly important when working with Latino clients, that they thought it was important to not just involve the primary person providing care, but as many people as possible who are involved in caregiving, especially in those multi-generational homes. So here's just one example of how we responded to these findings. Throughout the content, we tried to add cultural examples. So here an example of multi-generational living. So these two screenshots, I hope it's not too confusing, but I'll try to explain. So in this particular instance, caregivers are learning how to formulate an ABC plan, and the content or the module gives as an example a caregiver who is going through this process of formulating a plan. And so this is a caregiver whose wife leaves their home and gets lost, and that's the behavior that he's trying to target. And it walks them through a series of steps, but the step 2 in particular is asking that caregiver to gather information. And you'll see here on the bullet points the types of questions that the caregiver is asked, with the last one being like, who is around when your wife leaves the house and gets lost. And the voiceover or the caregiver responds with, just the two of us. There's nobody helping me to take care of her. So in this situation, we wanted to change it so that it's not just the two of them, but that it's a multi-generational home. And so instead, we changed the voiceover to say, just the two of us. My daughter was at work and the kids at school. And then later in step 4 of this same example, the caregiver begins brainstorming alternatives to address this issue. And you'll see all the bullet points here with the suggestions. You'll notice that none of the alternatives that the caregiver brainstormed involved asking family members and or friends for help, and that the third bullet point suggests hiring somebody for help. And given what we found, we thought that it'd be more appropriate to involve family members and not necessarily rely on hiring help. So in the adaptation to the voiceover, it used to say hiring somebody to keep an eye on her. And we changed it to doing the laundry when my daughter or grandchildren can keep an eye on her. And the final adaptations that we made were rewording the content to lower the reading level, to be inclusive of individuals with lower literacy levels. And we translated all the materials to Spanish to be inclusive of Spanish speakers. So in the original content was written at about an 8th grade reading level, which I think is pretty good, but we managed to further lower that to a 4th grade reading level. And then the content was available only in English, and now it's been translated to Spanish. So I've listed here some of the key takeaways that I think have implications for people that are working with this population. But I see that someone mentioned in the chat that these findings can be generalizable to all caregivers and patients. I see your comment, Angela, and that's exactly true. That I don't think this is necessarily just for our Latino caregivers, but that it could apply to caregivers from any racial or ethnic group. The first one being to provide more education about Alzheimer's disease and related dementias at diagnosis, and explaining that it's not part of the normal aging process, and using simple language to explain what causes dementia, and making sure to point out that people with dementia will begin to experience changes in mood and behavior as the disease progresses, so that caregivers aren't surprised and they have time to prepare for how to deal with this when it comes up. The second being to probe about behavioral and psychological symptoms many times and over multiple visits, and to give caregivers the opportunity to open up when they start to feel comfortable about doing so, and then letting families know that it is relevant to the conversation with their providers and that help is available if they need it. The third, avoiding describing the impact of caregiving as a burden, or using terms like problematic, challenging, and bothersome to describe symptoms, and simply letting the caregivers describe how caregiving impacts them in their own words. And then finally, considering the family unit and not just the primary person providing care, and being mindful that there are likely multiple people involved in providing care in one way or another, and that they would also benefit from education and skills training and added support. And I want to now acknowledge my collaborators and sponsors, Miriana Duran, who's a staff member at the School of Public Health and conducted most of the interviews, Rob Penfold at the KP Washington Health Research Institute, who's my primary mentor for my K-12, India Ornelas and James Ralston, who are my secondary mentors, and then finally Sumit Curry and Linda Terry, who developed the STAR-C intervention. And then finally, I want to acknowledge my K-12 funding, as well as the Alzheimer's Association, for supporting some of this adaptation work. And with that, I'll open it up to questions.
Hello, this is Angela. Can you hear me okay?
Mm-hmm.
I had to go to a new technology today, so sorry. No video today. Hey, of course, we're at the Memory Brain Wellness Center. Thank you so much for presenting this work. And this is really timely for me because we just had Bharat Gaster present their big project for primary caregiver training and all that kind of stuff. And we yesterday morning, and we ended the discussion with, they have a lot of material and a lot of fantastic resources. But I think a piece that they're working on, and a piece that a lot of places are working on, is sort of this idea about dementia reframing, about like these kind of pieces that are not calling dementia a burden all the time, and and also making it patient-centered. Like, hey, dementia is a disease that affects you, the person, and this is what you're going to experience, and this is what and directing it toward the person. So we talked about ways to make that more quote unquote user friendly, and also more culturally sensitive. And it may have been that your name and those names you just presented came up yesterday in a meeting. So if your spidey senses were tingling, that's why. Yeah. So anyway, I just wanted to bring that up, and also just to thank you for this work. And this is just why we need, more voices and more diverse and different experiences, because our model of dementia care continues to evolve and change from the old, like, professor tweedling their pencil, and as someone that's the professor tweedling her pencil. Like, I need more diverse help and experiences out there to help me. So thank you for being that. So I guess my question is, I am getting to the question, are you continuing to work on this model, and what would be your next steps for putting this out there? Would it be kind of more in early stage, in later stage? Like, where do you see the work going?
Oh, stage in terms of the disease?
Oh, yes. In terms of like, if you were going to focus on like next steps, I guess, would you focus more on like targeting people that are just getting their first diagnosis and how to work that, or maybe undiagnosed out there, you know, struggling in primary care with behaviors, and it's probably dementia, but no one said the word, you know, they're doing all the other things? Or would you focus more on like people who have known Alzheimer's and are struggling with behavior? I guess that's the question. Yeah.
Yeah, good question. In terms of next steps for this work, I'm actually submitting an R01 to NIA, which is due on February 1st. So I'm busy working on that, but that's to test this adapted intervention with the Latino population. And we're proposing partnering with a WPRN. And so we'd be recruiting from primary care practices across the WAMI region. And in that proposal, we are targeting people with a diagnosis of Alzheimer's or related dementias, and then screening people in terms of to identify people who are actually experiencing behavioral and psychological symptoms. So we have some criterion like at least 3 behaviors 3 times per week or something like that. In the current STAR VTF trial at Kaiser, they were using a new prescription for an antipsychotic medication as a proxy for identifying people who may be struggling with symptoms and their caregivers could benefit from the intervention. But they're finding that antipsychotic proxy is coming too late in the process, because at that point people are getting ready to transition to assisted living. So it's really hard to identify the right time to do this in a pragmatic way. When we spoke to caregivers at Kaiser, not necessarily Latinos, but just general population of caregivers, some of them said like, oh, why wasn't I offered this intervention sooner, like at diagnosis? And they talked about how they've already gone through a whole process of learning how to problem solve on their own, and that they would have been helpful to be prepared and know this in advance. But then there's also a drawback, like you wouldn't want to give this too early because then it might not be relevant. And it's really hard to determine when is the appropriate time, I think. But my colleagues and I have talked about maybe making the program available in early stages or at diagnosis, and then having, and caregivers can go through the modules that they see are appropriate for their current situation as it's happening. So that's one thought, but yeah, it's really difficult to identify the proper time in a pragmatic way.
Well, good luck on your R01. That's due tomorrow, basically.
David, do you have a question?
Yes, thank you for this wonderful presentation and work. I wonder about heterogeneity in the Latino population. And of course, it's hard when you're starting out and you're likely working with small numbers in the sample that you have. And at the same time, as you expand this work, I'm wondering if there might be some way of thinking about the Latino population as a very potentially heterogeneous population in which views might differ from one group to another or one family to another, and how you might envision managing heterogeneity in the sample.
Yeah, that's a good point. And we have thought about that. And we do acknowledge that there are a range of experiences and cultural values and beliefs and practices and all of that within the large umbrella of Latinos. And I think it would be really interesting in the future to ensure that we have representation from different nationalities and acculturation levels, because all of that impacts, the caregiving experience and practices and views of caregiving. At this point, as you've noted, our sample has been really small, and the majority have been like middle-aged adults who identify as Mexican. But I don't know. I think we will try to be sensitive and not assume that some of our findings apply to everybody, but leave room for, or state it in a way that acknowledges a range of experiences with the Latino population. Like some people, may experience this or feel this way or that way. And instead of applying it broadly to everyone, it's difficult, but I think it's important to keep that in mind.
Thank you.
Annie put a few things in the chat. I don't know if you're able to unmute or if you wanted to comment any more about that, Annie. Or Lauren also had some comments about some of the language that we use to communicate in general with caregivers of those with memory loss.
Yeah, hi, Kate. Sorry, I just took a big bite of breakfast when you asked me to mute, but what an amazing talk. Thank you so much for all the research that you're doing. I do palliative medicine, and a lot of times we think about the language and the words that we're choosing very carefully when we're speaking with families, because just any negative or overly positive connotation to a word that we might choose to use can really color what a family member takes away or what a patient takes away from our conversation. And so I just found it really interesting that, there were certain words that we use every day in the lexicon, and when we're speaking with our patients that really are kind of this like medically adjacent jargon. And I see us using a lot of these terms, like we're pretty good at replacing the true medical jargon terms with now lay language, like, we use kidney instead of nephrology. But I think these words that are kind of sneaky, still kind of medically jargony type of words like caregiver or like caregiver burden or burden, I think can sometimes, even though for us, they're the labels that we use and they're the language that we use and they're the words that we use to communicate with each other, particularly in research or clinical situations where we're just discussing patients together. I think sometimes those words translate poorly when we're actually speaking with our patients and families, or they just mean very different things when we're speaking with our patients and families. And it's just one other thing to be wary of. And I think your research highlights that and uncovers that as well. And I guess this other thing I was totally struck by was the stigma of the neuropsychological aspects of dementia, and how that's just something that I think kind of continually have to normalize, not just in dementia, but just mental health in general. But it's interesting that just, being Asian myself, I see similar aspects where, people don't want to talk about those things with anyone. in my culture. And so when that's what the manifestation of dementia presents, I think it's not always recognized as part of the dementia. And so that's just critical education that I think you also uncovered. And so important, but just overall working to destigmatize mental health in general, so important. So yeah, just wonderful work that you're doing. So thank you very much.
Oh, thank you for that comment.
David, I have a question about, yeah, sorry.
Oh, okay. Thank you so much. Really wonderful and important work. Thanks for presenting it. Question is sort of as you're doing the research and the work behind offering these really important trainings and support to family caregivers and care partners right now, what would you, are there sort of, what we usually do is we do as much as we can in terms of educating and supporting families at the bedside, and we use our interprofessional teams and we engage the Alzheimer's Association. Are any of your modules or resources actually available to support the care that we're giving at the bedside right now, or do we just have to wait and be patient?
Yeah, yeah, I get that question a lot. People want to use it now. Unfortunately, the modules right now are only available to people enrolled in the trial at Kaiser. But we're working really hard to make that widely available. As researchers, we don't want to put anything out there that doesn't have evidence to demonstrate efficacy. So we want to make sure that these, I guess that, yeah, it's really needed. We hear that, but we're taking the necessary steps to make sure that it works and people find it acceptable, et cetera, before widely distributing it. But that's our ultimate goal, to have it widely distributed.
Maggie, I'm sure you know this better than I do, but the area agencies on aging, I know King County's area agency on aging has integrated STAR-C into their work, particularly if you refer someone to their family caregiver support program. If it's someone with dementia, then they have some STAR-C trained case managers who can, essentially implement that program with folks. It's kind of ebbed and flowed how much support they have for it. And during the pandemic, it's been a little bit different. But when I last checked within the past year, they were offering STAR-C at least on a limited basis. So they have those supports, but at least the family caregiver support program, all of those leaders are trained in helping those caregivers who are supporting people living with memory loss. So there are resources available, not this exact one, but area agency on aging is still super helpful. And Maggie, I don't know if you know what they're doing with STAR-C right now.
No, thank you, Kate, for mentioning that. I have heard from Sue McCurry that it's either it's ongoing or it has in the past been implemented in Washington and Oregon, though it's the in-person intervention with the consultants. So yeah, thanks for mentioning that, Kate. The part that is not widely available is the online self-directed modules. But if people are interested in the in-person intervention, well, it's probably not in person right now, probably like phone calls or something, but that piece is available.
I had a question. Hi, I'm Gina. Thank you so much for your talk. It really resonated with me. So back when I was in Connecticut, before coming to University of Washington, my focus and interest is working with diverse older adults. And so I did kind of my own, I guess, pilot project of doing a qualitative study, interviewing caregivers caring for immigrant older adults. And so one of the questions that I asked was, what is your experience like being the caregiver of an older immigrant adult, especially one who has limited English proficiency. And so, a lot of the things that you mentioned definitely came up. And one of the other questions I asked was, have you ever heard of caregiver burden? And so I really appreciated, you going through that slide of, oh, it's not a burden, and, these terminologies, because that was exactly the same thing that came up. I was just curious because, we often use these terms a lot. And so just wondering kind of the, I guess, thought process of what that means in different, diverse communities. The one thing I would say that came up most commonly as a theme is that there aren't enough resources and they just don't even know where to find resources. And so a large part of that in my thought process, the work was never published, but part of that was for more of like community dissemination and just really being in the communities that services a lot of the, older adults and caregivers. And so I'm just wondering if there's any, envisionment or thought process to make adaptations to, community resources, or if you even know of any like pockets and areas that could be reached in that way, because I think that would have been the most helpful for a lot of, my caregivers and patients living with dementia.
Yeah, honestly, we haven't found a lot of resources in Washington State for Spanish-speaking caregivers, specifically for dementia. There's one program there are a couple of programs at CMAR that are for older adults and their caregivers, but I think that's in the time that I've been working on this project over the past 3 years, that's the closest thing that I've found that is for Spanish-speaking caregivers of older adults, and not even specifically dementia, though they do partner with the Alzheimer's Association. They have a person that goes into the clinic to have consultations with caregivers there. But in the central and eastern parts of the state, I'm not aware of any resources for Spanish-speaking caregivers. So there's a huge need.
And I think that's the case for many, because I'm always in search of Korean resources, just since, I'm always looking for things for my parents, which has been extremely challenging. And then in, times of COVID too, even like getting information about COVID has been really difficult. And I would say some of the resources that also lead into the resources that are possibly translated, the main website is in like completely in English. So then like, how do, people navigate that way to even get to these resources that might be helpful? So that's kind of been my struggle and challenge, not just for, finding things for my patients, but personally finding things as well. So yeah, so I just thought, I just ask if you had any, come across anything as well. So
yeah, unfortunately not. And you make a good point that some of these websites do have translations, but it's like on the top corner in really small font, like translate to Spanish. And then I don't know how the translation is done, but it's often not accurate. And so it's kind of wonky, but yeah, there's a lot of need.
Well, thank you so much for taking the time to share your amazing work with us and to answer all of our questions. And this was a really rich discussion, and I appreciate everyone adding your thoughts. And I really appreciate you, Dr. Ramirez, sharing your expertise and knowledge of what's going on more broadly in this area. So thank you so much. For those of you who haven't, please fill out the survey. And I hope everyone can get some rest this weekend and spend some time outside maybe. All right.
Thank you all. It was really nice being with you this morning.
Thanks so much. Take care, everyone.
Thank you.
Thank you again, Maggie. And I'll, oh, she's